My name is Alison Lee. I'm the Coordinator and FFT Clinical Supervisor for Families First. We were set up in 2007 as a community response to identified emotional, behavioural, psychological difficulties of youth affected by these issues in the South Dublin West area. We chose functional family therapy specifically after doing a review of evidence-based programmes family interventions. And I suppose looking back, there were family interventions were showing promising results, and that provided partially the rationale for choosing a programme like this. There was evidence to show that it did work with children and adolescents experiencing problems like conduct disorders, substance misuse, a wide range of problems. The cost of the treatment was way below other treatments for that particular client group. Siblings would also benefit, and I think also what was really important for us, that it had a very strong adherence fidelity built into the programme, which means then that you could evaluate your outcomes. And that was going to be really important for us as an agency, because we wanted to be able to demonstrate and just to see how effective this particular model would be. We spent a lot of time in developing relationships, and I think looking back on it, creating a working relationship with other agencies has played a huge role in our success, and that's having mutual respect. And very often the youth need an integrated pathway of care. So I think it's going to be really important that you spend a lot of time developing those kind of relationships. The practicalities can make or break you. So for example, you have to have a lead support coordinator to guide the practice. In our case then it was important to have the agreed referral system. Ideal number of therapists for a team was 3 to 6, because peer support is also very important for this programme. There was a web-based quality assurance, so like the practicalities of having IT that works, access to a two-way mirror when you're for supervision, again important. And yes, that staff can be released to attend supervision and training. These are all considerations, your development of your policies and procedures, all of that has to be put in place. So you've got very much a lot of work to do in terms of the preparation, but very worthwhile once you have that in place. The choosing of staff is going to be extremely important for this kind of model. You have to be very flexible in your way of thinking. Ideally, the qualifications are very much an honours degree in psychology, psychotherapy, behaviour analysis, or a social science discipline, but with at least 3 years of experience working with families. In addition, they have to be able to a driving licence. They have to be willing to work with families in their own home, and they have to be flexible about the hours that they work and open to the new way of working, to the monitoring, because there is what we call a continuous feedback system. It's an adherence tracking model. It helps therapists to stay on track, and it would track client outcomes, assessments and service delivery patterns. So that would be part of the training as well. The main challenge was getting other services to refer. Initially, you're the new kid on the block and you have to build up trust with other agencies. So there was a gap between the training and when the first families were actually referred. And ideally it is very important that therapists begin to see families as soon as the training begins. So that delay, I think, initially was an obstacle, but then again it is about the groundwork, and I can't emphasise how important it is to build those relationships. Not just for referral sources, but also remember this model has a very strong case management component to the generalisation phase. So equally you need to be aware of the other organisations so that you can help support your families in accessing if they need. At the time, it was developed for juveniles involved in criminal activity, and we would have thought initially that we would just target that particular client group, but very quickly learned that actually it worked very well with a wide range of issues. So we started to broaden our referral base, and of course then led to long waiting lists. The reality was initially that we limited our referral base, and it took us a while to realise then that obviously that this model worked with a wide range of issues. And of course the model itself, I think in an Irish context as well, I mean initially it would have said that you could complete therapy within 16 weeks. However, we found that the engagement process was a lot longer, so we were averaging around 22 sessions. The training was delivered by the programme developer, Professor Tom Sexton, and he would come to Ireland to deliver the trainings. As our training was over a 2-year period, and it would have involved clinical trainings, which practice use of advanced clinical trainings where you would directly experientially work with families in the room, videos, webinars. There were consultation days every 6 weeks, and then you have weekly supervision. The supervision is very much based on the cases that you're working with. So a therapist would present the case and then they would receive guidance and coaching along that. After 2 years, you would, obviously if you're successful, you would receive site accreditation. The third phase then is where a supervisor is identified from the team to take over that role, and that leads then to sustainability of the site. To help the implementation process, all therapists are trained in the use of a continuous feedback system. It's a web-based tracking system that allows the therapist to access, process and assessment information, which in turn allows them then to make very good clinical decisions and helps them to keep them on track. And it's a really important part of the FFT model, and that is one of the protocols you're expected to use this. In addition as well, remember you get instant feedback in terms of your service delivery. So for I as a supervisor then, not only can I respond very quickly if any difficulties come up for the therapist, but also I can track the service delivery profile of the agency. So that was extremely important, and you can make decisions and you can change and adapt to the data that's produced then. Between 2010 and 2014, we completed an evaluation study of FFT. We did a retrospective study, which was a retrospective study from 2007 to 2011, and then we completed a random control study from 2012 to 2014, and the results of that study indicated that it was very effective in an Irish context. As part of the RCT, there was a qualitative analysis where therapists, managers, referrers and the families themselves were also interviewed as part of the process to help us to get an understanding of what was working and what didn't work. Functional family therapy has been delivered worldwide throughout Europe, England and in Ireland. We are the first accredited site in Ireland, and we are currently delivering training now to, in collaboration with the South East Drug Task Force and the South East Substance Misuse, to teams down there, and we would hope to expand to other teams. There were a number of things that we would have done differently. The first, I suppose, is about the preparation piece, and I think giving us more lead-in time for that, because what we were trying to do is that you're trying to implement as well as learn a new clinical model, and that was difficult. In addition, I think the selection of staff is very, very important, and how we'd conduct the interviews, I think, would be a little bit different as well, because very often it's not just about academic qualifications that leads to the to somebody being able to work in an FFT way. There are clearly other personal attributes that are very, very important. Because there's a high level of monitoring, not every therapist is going to be suited to working in that way. So I think that would be something that we have modified over the years. The referral criteria, being a little bit more specific around that. So for example, we're going to realise that sometimes, you know, if you have a parent with a chronic substance misuse issue, well, family therapy will not be appropriate. I think it would be very important in the selection process that therapists have, ideally would have a background in psychotherapy and behaviour analysis, and at least 3 years of experience of working with families. In addition, you could have maybe an adolescent who has an moderate intellectual delay may not have the capacity to understand the kind of reframes that we would use throughout the therapy sessions. I would advise people implementing this programme to make sure that the team had a strong base in the theoretical knowledge of family therapy, particularly in a systemic way of working with families, and that would be an advantage. Having evidence makes a huge difference to you as a therapist. It's hugely motivating, because you could look at the pre and you look at the post measures, and you can see clinically the difference that's been made, not just what's happening in the room with the family, but you have hard evidence. So you would have, evaluated maybe the individual difficulties for the youth, and then when you finish, then you can look and you can see improvements across a wide range, from their emotional to their conduct, hyperactivity. You're able to measure these, and equally then for the family, it's very motivating for them, because they're doing the self-reports and they can see the improvements as well for themselves.